All right, well, I think we're recording. Thanks everybody for joining us. My name is Porter Leslie. I'm the CEO of Ametros. And today's webinar, we're getting into when is it appropriate to do a second opinion? And I gotta be honest, I've been looking forward to this one for a while. I've got two very esteemed guests with me. One is Paul Signolfi, the other is Ben Nwachukwu. And two guys that have really done great things in their respective fields. We're gonna have a good time. It's a snowy Boston here where I am. And I know, Paul, you're up north and Ben down in NYC today.
Yes.
That's right. I'm in New York.
Awesome. Well, I've got a little bit of background I'll give on each of these gentlemen, and then we've got a free-flowing conversation to jump into. So a little bit on Paul. He's the senior managing director at Ametros. Been with us for a couple of years now, and prior to that was the executive director and chairman of the Maine Workers' Compensation Board. And Paul, I wanted to get to come back to you in a second. I'm going to give Ben a quick intro as well. So Ben Nwachukwu is he's at the Hospital for Special Surgery in New York City. He's an orthopedic sports medicine doctor there. He's the co-director of research for their Medicine Institute over there. And if you look up the Hospital for Special Surgery, which I had to dig into a little bit for this, it's ranked for the last 10 plus years as the #1 hospital in the country for orthopedics. And so Ben is up there as co-director of their sports medicine practice. He's also been the team physician for the Chicago Bulls, for the White Sox, and he's the current physician for the New York Red Bull soccer team in New York. And on top of that, he launched a business about a year ago, which is BICMD, which does second opinions. And so part of the fun we'll have today is getting to know Ben a little bit about his business, what are second opinions, and then Paul, who has quite the career in workers' compensation as an attorney and regulator. We'll bounce it back and forth on how opinions can have their impact on a case and on a settlement and even beyond. With that, I wanted you guys to get to know our guests today a little bit more. So Paul, maybe you can give us a little bit of background on yourself.
Well, our audience may have guessed by this point that I'm clearly the underachiever in this group. Besides what Porter has already told you, I practiced law for 30 years as a trial lawyer with a real focus on workers' compensation. So the idea of second opinions is something that I dealt with when I represented claimants, but it was also something that came up with some regularity when I represented insurance companies and employers. I then became the executive director and chair of the Maine board. And again, it was something, second opinions were something I was very concerned with to make sure that the playing field was leveled for those who participate in our system. As Porter said, I joined Ametros approximately two years ago. It was a nice place to go after my legal practice and after my regulatory practice, because I can now share with the Ametros community and those that we service. I can share the experiences that I've had both as a regulator and as a trial lawyer. Two other things I'm doing these days in workers' compensation, which I think are important, is that I'm the vice president of Kids Chance Maine. Those of you in the workers' compensation industry are familiar with Kids Chance, and I'm on the board of research for the Workers' Compensation Research Institute, a think tank in Cambridge, Massachusetts. It really focuses on workers' compensation topics. That's about it, Porter, for who I am.
And Paul, if I recall, you surrounded yourself with doctors.
There is some truth to that. I'm married to one, and I have a son who is a gastroenterologist. Yes.
In warming up for this, Paul and Ben have gone beyond my knowledge on different pathologies and things like that. So it'll make for a rich conversation today. Thanks, Paul. And Ben, can you introduce yourself as well?
Yeah, well, thank you, Porter. I mean, I don't know how to follow that introduction, but yeah, obviously Porter and I go back to college. Went to Columbia together and played basketball there. Porter made me promise as part of the terms of coming on this webinar that I could not talk about his basketball career. So he keep that off limits. Yeah, you know.
More when you dunked on me, we were gonna leave that out.
All right. You just you went there with it. All right, fine. Yes, I dunked on you. I'll claim it. You know, I was fortunate enough to go into medicine and really developed a love for orthopedic surgery. You know, just through my own experiences as a student athlete, having knee pain, orthopedic injuries, and I actually ended up rupturing my Achilles in medical school. And you know, even as a medical student who's in the medicine industry, I was so lost during that time in terms of really trying to figure out who was a good doctor. And I realized at that point that, you know, unfortunately, one of the dirty secrets about medicine is that the people who actually know who are the good doctors are other doctors, right? There was really no way for me to understand who was the best person to repair my Achilles. Luckily, I had my Achilles repaired by the team physician for New England Patriots. One of the perks of being a med student at Harvard, I guess. But I had that insider access, and so fast forward, you know, 10 years, and you know, I'm now an orthopedic surgeon, taking care of professional athletes for a living. And you know, one of the things that people don't understand is that professional athletes actually are workers' comp patients, right? So when you do surgery on a professional athlete, that's a workers' comp injury, and so that's insider access. And so you know, the genesis of BICMD, and you know, we can talk about this, you know, a little bit, was the idea that, you know, I want to create that for everyone. I want to have that access to the best, lift the veil, and provide that insider access to the best physicians, and take away the guesswork.
Really interesting to hear. And humor us for a minute. I know a few months ago, or end of last year, you were one of the few select physicians in the country that went into the NBA bubble, right? And were you treating players there?
Yeah, so the NBA bubble experience was actually pretty incredible. You know, I used to say it was a once in a lifetime experience. I thought people would go away from the bubble, but it turns out that NCAA is going to do another bubble. So I haven't gotten asked to do that yet. So hopefully, you know, hopefully I won't. But no, the bubble experience, honestly, it was tremendous. It was a great experience. It felt like summer camp, but with doctors and NBA players and media. And it was a surreal experience in the Disney, you know, in Disney World, right? And so obviously everyone knows about the strict measures to get into the bubble. I had to quarantine for 7 days. You had daily testing. You know, you had wristbands that monitored your temperature, that told you if you were too close to someone else with a wristband, so that you could ensure social distancing. But the bubble was a success, and you know, no one tested positive for COVID, you know, during that time when it was really at the height of COVID. But as a team physician, it was a very unique and different opportunity where I was living, you know, down the hall from my patients, essentially, right? You know, athletic trainers would, you know, come to my room, see me in the, you know, quote unquote lunch hall, and talk to me about an injury. And then, you know, we would assess the player right there. And one of the other things that you don't actually get in real life, or, you know, in the regular day-to-day of being a team physician, is that, you know, there were 5 orthopedic surgeons covering 22 teams. So you basically covered every team in the NBA. So I was in every NBA team's locker room. It's pretty tremendous. And I would say I made some, you know, hopefully lifelong friends from that experience.
Ben, at some point, we're going to get to the substance of what we're supposed to be discussing today, but I'm really curious. You know, people can't tell how big a man you are from the screen, but you're about 6'8", aren't you?
Yeah, that's right. I'm 6'8". My playing weight was 260, but you know, I lost a lot of mass since then, and you know, I'm a little bit more slender now.
But my question is, did you play any pickup games with these guys?
That, you know, it's a really great question, and unfortunately, they didn't have a pickup basketball court, right? And so it was the people who created the NBA bubble. They did such a great job architecting all of the, you know, safety measures and the food and the this and the that. But you know, I was like, I want to play pickup basketball. I'm covering basketball every day. I want to just, you know, pick up a ball and shoot. And you know, all they had was pickleball. I'd never even heard of pickleball until the summer. I'm like, what is this pickleball thing that everyone's doing?
That's an amazing experience, and I'm sure amongst the NBA players, you just look like an average guy, though.
So it's funny, right? So Paul, to your point, I'm 6'8". I sort of have the physique of an NBA player. I look younger than I am, and it's always one of those interesting things where people do a double take and they're like, "Oh, you see an NBA player," and then they see some wrinkles and maybe I'm just not as cool as an NBA player, and you can always see the disappointment and the crestfallenness of people. I'm like, I'm sorry, I'm just a team physician. I'm not important.
Well, Ben, I remember being in college, you were going to do med school, and then keeping in touch with you over the years. You didn't just do med school, right? It wasn't quite enough. So tell us a little bit about your journey there, and maybe how that's tying into your business venture today.
Yeah, that's a great segue. And so in 2010, that was around the time of the Affordable Care Act, and there was a lot of scrutiny and trying to understand what are some of the cost drivers in healthcare. And I had the privilege of going to Harvard Med School, and Harvard Med at that time, they said, look, to be able to change the healthcare system, we need physician leaders. We need to train the next generation of doctors to understand business. And so from our class of 160 students, they chose 10 students to get a combined MD and MBA. And you were allowed to apply, and I applied, and I was selected to go to Harvard Business School as well. So I spent extra time in Boston getting an MBA from Harvard. And for me, that was very transformational. It allowed me to meld my understanding of medicine as well as my understanding of business. And when people mention business, they think about dollars and cents, but it's not dollars and cents. It's about how to design and redesign healthcare systems, how to operationalize change, and how to think about value-driven healthcare. And right now, value-driven healthcare is a buzzword. But during my time at HBS, I really spent a lot of time thinking about that and trying to understand that. And then as a result of that, I spent some time working with a second opinion company, and I took my learnings from that time to formulate that into what has turned into BICMD, which I think is an opportunity to really elevate the care that's provided to patients and injured individuals, and to actually provide value to the healthcare ecosystem.
So maybe we start digging into the content. So what is a second opinion? We'll start there.
Yeah. So a second opinion can come in various flavors, and very simply put, a second opinion is for someone who's had an initial opinion and has some residual questions, or just wants more clarification, right? And so in my clinical practice, in my day-to-day, I'll often see second opinions where people will have an opinion. So I'm at Hospital for Special Surgery, which is what we call a tertiary referral center, where it's sort of the end road when it comes to opinions, right? So I see a fair number of second and sometimes even third opinions as part of my practice. And so sometimes people will come to me to better understand, one, is my surgery needed? Two, just a sanity check to make sure that the doctor, who maybe doesn't have the same reputation, that they agree with the treatment path. And three, it's sometimes it's just actually just recommended to get a second opinion, right? If I were to have an orthopedic procedure, I would have gotten a second opinion. When I ruptured my Achilles, I did not get a second opinion. And look, I at that time didn't understand that there were multiple ways to repair an Achilles tendon. I actually didn't even know that not having surgery was an option, right? And nowadays, if I saw a patient with an Achilles tendon rupture, I would have a very frank discussion with them and say, look, do you think you're going to be Kobe Bryant? And, do you need the push-off strength that an Achilles tendon repair will give you? Or are you okay, doing the Peloton and not being able to dunk anymore? And look, I haven't dunked since I ruptured my Achilles. And so, in hindsight, probably non-operative treatment would have been a great treatment option for me, right? And so
that's to me, so you won't be dunking on me again. Good to hear.
No, don't worry, Porter. You're safe. You're safe now. But look, I think that sometimes doctors have their biases, and if you're going to have an invasive treatment, a second opinion is very valuable. And so those are the certain flavors of second opinions. And, beyond that, it can get more nuanced, right? And so there are questions around who are the people who drive second opinions, right? So a second opinion can be initiated by the patient themselves, where they just want, clarification around their diagnoses, right? Unfortunately, the way that healthcare is structured right now, hospitals are trying to drive volume, doctors are trying to see more patients, and you'll be lucky if you get 5 minutes, right? And unfortunately, that's not enough. And sometimes you don't want to go to Dr. Google to understand about the risks and benefits of your surgery and your treatment options. And so sometimes patients will try and get a second opinion just to have a doctor with better bedside manner or to learn more. They'll come in for me sometimes with a notebook of questions, and we'll just sit down and we're like, look, we know your diagnosis. Let's go through the questions. And then sometimes second opinions are driven by enterprises, right? So a self-insured employer may want to just mandate that all of their employees have a second opinion when surgery is recommended, because sometimes surgery is over-indicated and you want to make sure that it's the right treatment path before you spend money. And we know that second opinions bend the cost curve and drive down costs.
Yeah, and that's a great segue.
In preparation for this, I went out and did some research on the topic second opinions, and was frankly surprised at one of the things that popped up with some frequency in the research, and that is how many times the second opinion comes up with a diagnosis which is different than the initial opinion. What's been your experience in that regard?
Yeah, so it's twofold. So one is, with the second opinion, what is the frequency of change of the diagnosis, right? So in the musculoskeletal space, actually, the diagnosis tends to be the same around 90% of the time, because now we have advanced imaging and things like that. It's really about the treatment of the diagnosis. What do we do with that Achilles tendon rupture? And they actually have studied this. There's data behind it. And we know that in the musculoskeletal space, approximately 25% of patients who are recommended for surgery will have a changed diagnosis to non-operative treatment with a second opinion. And so, why is that? There's a number of reasons for that, but that's kind of where we're at in terms of the changed diagnosis with a second opinion.
And Paul, speaking from your experience in the work comp space, how did you see second opinions come up on a case?
I think Ben has put I'm going to comment about orthopedic surgeons at the end of this answer, but I think Ben has put his finger on it. And that is, sometimes people just want to have somebody else look at them and say, yes, this is what's wrong with you. This is the diagnosis. And here are your treatment options. You've been recommended you follow this option, but really these are the other things that are available to you, just so people have a better appreciation. I also saw cases, and I also had cases where I requested a second opinion because the primary treating physician wouldn't give opinions on some of the issues that were important to my case. Most critically, for example, did this historical event at work cause this pathology? There were some physicians that I found were extremely reluctant to issue causation opinions, or there were physicians who liked to do surgery, they were good at it, but really didn't want to write reports that were thorough enough to help me in the prosecution of the case, or in the alternative, in the defense of a case. So I use second opinions just to get better opinions in terms of the way the opinion is written. Now, one of the criticisms frequently of orthopedic surgeons, and I've heard this numerous times during the course of my career, is that you're trained to do surgery. That's what you primarily do. And as a result, you see a patient, you treat him conservatively for the afternoon, and tomorrow morning you're going to want to do surgery. Is that a fair criticism of the orthopedic community, Ben?
Look, I think that, I'm going to speak politically here as an orthopedic surgeon. I think that there can at times be misaligned incentives, right? Where the system can essentially incentivize orthopedic surgeons to be procedural based, right? And so there is, reimbursement by procedure. And, in general, what I think is that the surgeons who hold themselves to the highest level, and I can't quote any literature on this, but you know, where I work and my colleagues, you hold yourself to the highest cause to, you know, do surgeries that are indicated, right? But we all have our biases, and sometimes to a hammer, everything is a nail, right?
Yeah.
Is an expression. And so that's where the idea of impartiality comes in, right? And so you want to get a second opinion from someone who may not do surgery on you and someone who's independent, right? And that is sort of the genesis of the idea, and not to steal your thunder, Paul, of this independent medical exam, right? Where you say, look, this doctor has no incentive to operate on you. And this doctor is being given a premium to really spend time with you and provide a comprehensive report. And that's going to be independent, and it's going to be, you know, the final say kind of thing. And so that, I think that is the benefit in terms of dissociating the surgeon from their incentive. And look, that's what we strive to do, right? So we really feel that the doctors as part of our service who provide second opinions are impartial, right? Because they are oftentimes remote. They're not involved in taking care of these patients, and they can provide guidance to the treating care team. They can provide guidance to the enterprise about whether or not care is medically necessary, and the next best treatment options.
Mm-hmm. I guess at Ametros, you know, we're dealing with folks that have had an injury and they've settled their case, and so their freedom to treat is wide open. They can use a second opinion to make their own decision. But Paul, I know you've kind of walked the journey of cases before settlement, where a second opinion or an IME can be impactful. Where would an attorney think about bringing that into a case, and when does it make sense? And have you had cases? I know you always have a good story. Have you had cases where it's been a pivotal part of a case that you've represented?
I have. I've had situations where people asked if I would represent them in a case and have them come into my office and describe what was going on with them. I remember distinctly in preparation for this presentation, I thought about some of my old cases, but I remember distinctly a woman coming in telling me about a lifting injury that she had, describing these odd sensations that she was having going down her leg. She pulled up her pants and showed me her calf and showed that she had what I perceived to be as a non-medically trained layperson, muscle wasting, and she's being treated for a back sprain. And I can tell you what I did is immediately after she left my office, I called a friend who was an orthopedic surgeon, and I said, would you consider seeing this woman? I think there's a problem with this case. And she was being paid voluntarily by her employer. Her employer picked up the case and diagnosed, and the physician diagnosed it as a back strain. She was sent over to the orthopedic surgeon within the next week. He called me immediately and said, this woman has a discrete herniation. She's got significant problems, and I'm going to recommend that she be seen immediately by one of our neurosurgeons in the city. And that's exactly what he did. And it turns out that she was taken to surgery a couple of days later with, in fact, a discrete herniation that required surgical repair. So that's one case, Porter. But that case, you know, I'll never forget that, because it was just happenstance that I saw her, and it was happenstance also that the doctor who issued the second opinion disagreed entirely with the diagnosis and thought it was almost a crisis situation for her.
Wow. And that would sound like you were on the side representing an employee. I mean, I guess employers as well can reach out. Ben, how does somebody get this started? I know there's an element at BICMD to telehealth. So what have you guys been building over there?
Yeah, so we've fully built our platform. So we are, you know, we're built, we're live. So on the sort of, you know, front store, you can certainly just, as a layperson, you can sign up at bicmd.com. You can actually create a profile. You can go through and you can, you know, select an orthopedic surgeon. And, you know, look, when I say we take out the guesswork, we have actually a choosing algorithm where we basically go through and we ask patients, 5 or 6 questions that really pinpoint who is the best expert for them, right? So we ask them, what body part that is hurting, right? So from drop down menu, they'll be able to pick, is it my hip, is it my knees and my shoulder? I have my biases built into the business, but I think that they're good biases. I'm very much a believer in the focus factory, right? And the idea that if you are a specialist and you see a certain condition all the time and you treat a certain body part all the time, you're going to have the best outcome. And it turns out that there's good literature to support that. And so we have body part musculoskeletal experts who are hip specialists and knee specialists and shoulder specialists. And so the client will select the body part. If they know what specialty, they can click that, right? So, hip sports medicine is a little different than hip arthritis. And then there will be some, nuances around preferences, right? Do you want to see an orthopedic surgeon who's close in proximity to you, right? Is this someone that you potentially may want to see in person to operate on you? Do you want someone who's available right now, or do you just want the best person? And you'll wait to see what their calendar is. And when you sign up and create this profile, you'll be given a choice of 3 doctors to choose from, who are uniquely matched to your problem and your condition, and you'll be able to select an encounter. And so that's the direct to the consumer, right? This is stepping outside of medicine and creating a unique experience that basically takes away the guesswork. Beyond that, we have, go ahead, Paul.
Yeah, well, one of the things, when you and I first started talking some time ago about what you were doing, one of my concern was you and your partner, Riley, another physician down in New York, have this business that you've set up, but what if I'm in California and I'd like to see a California physician? And I'd like you to have you explain to us that you're affiliated with orthopedic surgeons all over the country. Is that correct?
That's right, Paul. So since we talked, actually, look, our business, or since we initially talked, I should say, obviously we've been developing this relationship over some time, and I'm super excited that Ametros and BICMD have, formalized our collaboration. We now have 80 orthopedic surgeons on our platform. We have a national footprint, right? And we cover every geography in terms of large metropolis. And so as part of our choosing algorithm, if you live in LA and you want an orthopedic surgeon in LA that treats hips, we'll find someone for you. We have those on our platform. And, because that's important. And look, the ultimate end goal here, and I think this is where we can really serve Ametros well, is that, there are certain things, one is, do you need surgery? Do you not need surgery? Is this appropriate? But sometimes, you just want to know who is the best person that treats this problem around me, right? And we know that you can't necessarily trust Google reviews, right? And so, we take that guesswork out, and you can choose that person who's in your locale who can treat you.
And you've mentioned Google reviews twice so far in this presentation. Is that an annoyance to a practitioner to have somebody do their own independent research, look at their complaints, their physical complaints associated with something happening to them, going out on the web and trying to come up with their own diagnosis? And let me tell you the context that I asked that question. My son did part of his training in Palo Alto, California, and he would say that he had to deal with patients who were very sophisticated, smart people, did a lot of research, and they would come in, tell him their symptoms, and then tell him their diagnoses. And he would invariably say, yes, that's all interesting, except you missed this little piece over here, and this is the critical part of the diagnosis as far as I'm concerned. What's your experience been in that regard?
Yeah, in terms of are Google reviews an annoyance for the doctors, or?
Yeah. Or do you come in with the patients come in with their own diagnoses based on their own research out on the web?
Yeah, so that's a two-part question. I think one, Google reviews are, personally, I welcome them. I think that the feedback is helpful. I think that so the person who is going to leave the Google review is also the person who's most likely to come in with a notebook of questions and, tell you that they, have looked up on this website and that website and try to, take you to med school. And so that can certainly be challenging. But again, I actually also welcome that, right? Because I think that those patients are actually some of the happiest patients, right? When you actually provide them with a clear diagnosis and a clear answer, it sort of elevates the level of your conversation, right? Because they come in armed with a certain level of questions. So to give you a very concrete example, right? This often happens with me for ACL reconstructions, right? You tear your ACL. If you're under 55, you should probably have your ACL reconstructed. If you do twisting activities, you should probably have your ACL reconstructed. And that's kind of a no-brainer. But if you are let's pick a number, a 42-year-old weekend warrior, what grafts should you use, right? And you're like, wait, what? I thought that the first step was whether or not I need surgery. But yeah, what graft should you use? Should I harvest your ACL from your patella tendon? Should I use it from your quad tendon? Should I use it from your hamstring tendon? Should I use an allograft from a cadaver? And there's a lot of nuances, right? And so I will sometimes get patients come in and, they'll say, hey, I heard that if you harvest my patella tendon, I'll have a lot of kneeling pain. And that's some people may find that annoying, but I'm like, yeah, you're fully informed and I can help guide you and say, look, you probably, the kneeling pain is only 10% because I know the literature, right? So it's like the likelihood of you having kneeling pain is low. What sports do? You probably would benefit from a quad tendon graft as opposed to a patella tendon graft, less incidence of kneeling pain. So you start up at a little bit of a higher level. If you're willing to engage in the discourse with the patient. And, some doctors are kind of like, I want to just tell you what it is and not have to explain my rationale. I'm very much, and I think and I don't want to call myself a good doctor. I think I am, but I think a lot of good doctors are willing to have that discourse where it's a shared decision-making process, because ultimately before you cut into someone and, they put their trust in you, they should be fully informed of their options and choices.
Mm-hmm. Yeah, Bennett, you reminded me when we rolled out our partnership a couple months ago, you came and spoke to our staff, and then immediately after I got 5 or 6 messages like, can Ben or Riley take a look at this? Our team was wondering how to use you guys, and you kind of explained the self-service setup, but you've also mentioned that maybe enterprise level, an employer or carrier might be able to use you guys, and how is that set up?
Yeah, so that's a great segue. And so, the second opinion space, right? When you look at, and Paul, I'm sure when you go with second opinion, there are a lot of second opinion companies out there, right? And so, BICMD, we didn't invent the second opinion market, but we are trying to make it better, and we're trying to, provide access to actually the best doctors, right? I've sort of peeked under the hood of some of other second opinion companies, and the quality of the physicians that you get can sometimes be unclear, and we're verifiably the best. And so why would a insurer or a large employer, self-insured employer, want to get a second opinion? Well, I already mentioned it kind of in passing that 25% of surgeries are over-indicated, and so in that situation, some employers, as a way to drive down the cost curve, will mandate that a second opinion is obtained for certain surgeries before the surgery is approved, right? And sometimes, they'll say maybe we don't need to get a second opinion for every surgery, but for CPT codes that are high cost or for surgeries that are often over-indicated. And so we know that back surgery, for example, is lumbar spine fusion is something that sometimes can be done when physical therapy or injections can be better suited. And so enterprises will then come to BICMD and say, look, we want to send cases to you for a review. We had an insurer come to us and inquire about having us be part of the prior authorization process, right? And targeting certain CPT codes as part of the prior auth and having human review. And so that's the flavor of how enterprises come to see us. And again, musculoskeletal problems are a huge problem for laborers, right? For workforces. 1 in 2 Americans have a musculoskeletal problem, and 1 in 2 workers, 1 in 2 manual laborers have back pain. And so what BICMD, what our final roadmap is, right now we have, 80 orthopedic surgeons, but we're working on partnerships in the physical therapy space and in the AI space so that we can provide a comprehensive musculoskeletal solution where, if you have a worker with a musculoskeletal problem, we can provide an opinion, whether that's first or second opinion, and then provide you with treatment, whether that's surgery or physical therapy or home-based therapeutics.
And Ben, while you were talking, we got a question come in, and I'll remind the audience, if you guys have a question, you can write it in the chat. The question is, for any surgery, should you get a second opinion? In other words, under what circumstances is it not necessary? And maybe that's interesting for you to talk about which surgeries really make sense for a second opinion, and maybe there's other ones that are not as critical.
Yeah, I think that there are certain situations where, there are, and I would say that these are probably more defined by the institution or, clinical protocols, right, that are established. So if you have met certain criteria, right, and surgery is recommended, then yeah, a second opinion is not needed. So something that jumps to mind for me is knee arthritis or hip arthritis, right? If you have had x-rays that demonstrate that you have knee arthritis, hip arthritis, you've been living with it for several years, you've tried injections, you've tried physical therapy, and you've seen an orthopedic surgeon, and they recommend a knee replacement, it's kind of a no-brainer. Yeah, I think surgery is a good idea. You've exhausted conservative treatment options. And there are certainly nuances in doing knee and hip replacement, right? But ultimately, that's sort of it's very minor nuances, and the outcomes are actually pretty much the same despite surgical technique. And patients will often get surprised when I tell them that.
It sounds like arthritis, maybe not a big one, but where do you see it maybe the most over-indication or mistakes made? What type of surgery would you say, hey, that's really one you should have a second set of eyes on?
Yeah, I think in general, spine surgery, because, and that's why, there's a lot of sort of, attention paid to back pain, because, back pain is a highly prevalent problem. And, back pain can be multifactorial. It can be as a result of the muscles. It can be as a result of, just general arthritis of the spine. It can be as a result of disc problem. And sometimes patients can get funneled down the spine surgery pathway and spinal fusion. And unfortunately, that's a step that you can't really go back from. You can't unfuse the spine. And then, we're finding that with spine fusion, there are, there can be what's called adjacent segment disease, where you have to get future spine surgery, future fusions. And you can have associated opioid consumption issues, and it can just become very tricky. And so I would say that before someone commits to back surgery, they should certainly get a second opinion.
And Ben, while you're talking, maybe one that's interesting for both you and Paul to chime in on is, the question is, do you look at second opinions the same as an independent medical exam? And how do you differentiate the two?
That's a very good question.
Yeah, that's a good question. And Paul, maybe I'll take it first, and then you can chime in. So, an IME. So I would say the second opinion is the umbrella term, right? So that is a second opinion, and under that umbrella term of second opinion is what an IME slots in. And for those that don't know, an IME stands for independent medical examination. And so an independent medical examination is what we alluded to earlier, where you are getting an opinion from someone who's not treating the patient and is providing an assessment. The difference between IMEs and general, second opinions is that it's a specific sort of second opinion that often has legal implications. and it often will be used to adjudicate claims and return to work status and things like that. It also has implications for the doctor usually, because the doctor who's doing the IME has to be willing to testify to the things that are put in the IME. And then IME is more tightly regulated. So a second opinion does not fall necessarily, just a general second opinion, I should say, does not fall under state jurisdiction, but an IME is subject to state by state regulation. That's the way I view it. And Paul, feel free to correct me and give me the legal lens.
No, I think, Ben, you're right on point. I think there is a distinction between a second opinion and an independent medical exam. So let me tell you about the statutory scheme with which I'm most familiar, and that's just in the state of Maine. In Maine, we have two provisions that allow for a second look at a patient. And I used to refer to them as independent medical examination, small I, and independent medical examination, capital I. But I think in having dealt with you over the recent months, I think I would refer to one of them as a second opinion, and then the second one as an independent medical exam. And the distinction really is everybody should have a right to have, whether you're an employer or you're an employee, should have a right to have a physician of your own choosing evaluate and determine what the nature and extent of your injury is and what the appropriate treatment is. Independent medical examination, in contrast, is usually focused on some very specific legal issues. Permanent impairment, for example, is a huge issue. Maximum medical improvement is also a huge issue. Speaking of that, there's a bill pending now that I read about in New Jersey where they're going to by statute make it so that people who've reached the stage of maximum medical improvement in workers' compensation get some preferential treatment in the hiring process now of certain companies. But so those are very important legal concepts that may not be touched on at all in the second opinion. And my comment earlier, when I gave the example of my client who had the back injury, I didn't want to give the impression that second opinions are only important for employees. They're important for employers too. And employers really want to get it right. That's been my experience. They want to make sure that their valued employee is appropriately diagnosed, is appropriately treated, and gets themselves back on track. So I think second opinions are critically important to employers and insurance carriers as much as they are for employees.
Thanks, guys. And actually, we're getting questions rolling in. So and they're segueing well with some of the things we wanted to cover. So good question was, what are the economics? How profitable is a second opinion for a doctor? And is it a distraction from surgery? And I think included in this is, it says most don't like contradicting doctors. So in a way, you're challenging maybe another doctor's approach. So what is the passion that you brought to the space, Ben? And maybe you can talk about that a bit, and the cost too. How does this work business-wise?
Yeah, that's a great question. And the way that we think about the second opinion business at BICMD is twofold. I like to think about it as, redesigning healthcare, right? Or rethinking how healthcare is given, right? And sometimes people will think about this as healthcare. This is a medical opinion from an individual, from an expert who is at the very top of their field. And look, just to throw out some names, and Bob Anderson, who is a famed, esteemed foot and ankle surgeon, he's one of our doctors, and he really enjoys doing this, right? At the end of the day, all of our doctors, we all swore the Hippocratic Oath, and we want to provide care. We want to help people make sure that they feel comfortable in their opinion. And so that's really answering the second part in terms of contradicting other doctors, is that the doctors on our platform will do what's right, and at the end, the client, the patient, will get a report that has my name on it, that has the doctor's name on it, and you better stand behind that, right? And so doctors will not sort of go with an opinion that's a bad opinion for the sake of not wanting to contradict doctors. I don't think that that is necessarily something that's true. Doctors will generally do what they think is the most appropriate. In terms of the economics, so, we pay the doctors a rate that's sort of negotiated between the doctor and market forces, right? And the second opinion industry has, certain going rates. And it's certainly, it's definitely not the same as surgery, and it's not considered a distraction. It's just part of the job, in the same way that Paul does other things that are outside of his, day to day. A doctor in the evenings, does second opinions, right? Sometimes, I'll do this work on the weekends on a Saturday. I don't have any cases then. And so it's certainly part of the, multifaceted career of being an orthopedic surgeon. And so that's the economics for the doctor. In terms of the economics for the institution or for the enterprise, we have negotiated rates that we negotiate with our enterprise clients, and obviously happy to discuss those further. And then when using our platform, we have certain rates that are set actually by the doctor based on their availability and based on their own preference, right? So some doctors, to make themselves available, right? So our doctors are available 24/7 actually on the platform. And so if you want to have an on-demand consultation, right, we have an on-demand services where it's not just a second opinion, but you can actually get a video call with an orthopedic surgeon right then and there. Some doctors, set a price that they feel is a fair price to, for you to chat with them at 6 p.m. on a Saturday or on a Sunday. We don't accept insurance. And again, this is the idea that we are not in the traditional mode of healthcare, right? This is not a 2-minute, 3-minute consult. This is a 40-minute video encounter where our expert has reviewed your medical record, has thought about it carefully, is going to be on a video call with you for 30 to 40 minutes where you go over the issues at hand. And then at the end, they will provide you with a clinical summary that summarizes your diagnosis, your imaging, and provides you with a thoughtful next step.
Ben, how do you deal with a situation where you review a file, you have the opportunity to interact with the patient, and you think there's a piece of the puzzle that's missing? What really should be done here is this diagnostic test, this MRI, this CT scan, this this whatever. What would you do in a situation like that?
Yeah,
in order to have the exam be comprehensive, you need to know more.
That's exactly right. So we have virtual care facilitators who are actually nurses who have a clinical background, obviously. And what they will do is they'll review cases as they are booked with our experts to make sure that it is appropriate for the doctor and for the patient. So if, for example, someone had, wanted a second opinion on, metastatic lung disease to the bone, and they had no imaging, our virtual care facilitator would say, would work with that client to try to obtain the imaging. And if the imaging is just not obtainable and the consult is not going to be useful, then we will either reschedule, cancel. But generally, we try to make sure that the clinical relevance is as high as possible. And so we have systems in place to prevent that.
Yeah, you're a business school guy, so you've made reference to enterprise several times.
Yeah.
Could I, let's assume I was out actively practicing, and I had a client who needed to see somebody like you for a second opinion. Could I, as a private attorney, make the referral to you, or would I have to be some type of official entity of some sort in order to be able to do that?
Well, it depends on what you mean by a private attorney. Are you going to use this to subpoena me, or?
No, I have a client who needs to have a second opinion. Can I connect with you and say, Ben, or one of you, Riley, or one of your other people, could you set something up with my client here, John Jones? I think he needs to have somebody look at what's going on with him medically.
Absolutely. So we have several ways of doing this. We have multiple touch points, multiple entry points. So first off, I'm highly accessible. I tend not to sleep very much, so I'm always checking my email. You can just email me personally. But if you don't know my personal email, which I also have no problem giving any of the attendees of the webinar, you can just simply sign on to our platform, right? A patient can create a profile on our platform, BICMD.com, and they can actually go through the algorithm and select the person that they want. If, for example, you were to say, Ben, I really think that this person is right for you, we actually have individual doctor portals where you can type in the doctor's last name and their first initial, and you can be routed directly to that doctor for a consultation based on their calendar availability. So lots of touch points there.
We've got more questions rolling in for you guys, which is exciting. I think we can go about 10 minutes over if the questions keep coming. So this question is a good one, and I think we see it a lot in the work comp space before they settle. After they settle, they have freedom with us; they could set up their own appointments. But this is quite frequently a topic. The question is it difficult for a physician to determine additional injury related to the initial injury? So the topic of relatedness, i.e., and the suggestion here is they're wearing a boot for too long that then caused knee or hip or back pain. So the relatedness of injury, is that something that you dig into with second opinions, Ben?
Yeah, I think you absolutely can. I think that, and I see this in my practice where, people have certain underlying predispositions where, immobilization, for example, in a boot or being on crutches, et cetera, will trigger a certain problem. So a common one is shoulder pain as a result of being on crutches, right? Where you injure your foot and you're crutching around, and then all of a sudden you have rotator cuff inflammation, or you have a pre-existing partial rotator cuff tear that, because of the crutch use, progresses to a full rotator cuff tear. So to answer the question, very simply, yes. You just need to have a physician who asks a good clinical history and is able to relate the clinical timeline from the injury, subsequent events to your current clinical status.
And Paul, I know you probably had tons of cases where relatedness was a big factor. And did you?
And the analysis for an attorney is essentially, but for this injury, would you have had this new medical symptom complex? I had a case once where I had a fellow, believe it or not, was young. He very badly injured his knee. He had a couple of surgeries on his knee, and then the orthopedic surgeon decided to fuse his knee. So he ended up with a fused knee, and he developed severe hip problems. He developed a severe back problem. He was ambulating with crutches. He slipped and fell, and he tore his rotator cuff because of that. So there was a whole series of subsequent injuries that could be directly tied back to the original knee injury.
So maybe a big question for you guys, and then we'll see if there's any more that roll in. We did get one question from a prospective medical student, Ben, asking you what inspired you to pursue a career in medicine. And maybe you can talk about that and also dovetail it with what comes next. What's the future of what you're doing in medicine? Where do you see this going? Because I think probably the future is what inspired you in some ways. So I'm curious to hear kind of what drove you into the field, and where do we go next from here?
Yeah, so I think my earliest inspiration is my mom, right? My mom is a nurse. I grew up in London, and I grew up, it was me and my mom, and she was a nurse, and I just know how hard it was for her, to raise me and to do everything that she did as an immigrant. We immigrated from Nigeria to London. And I just remember thinking, like, oh my God, your job probably sucks because you come home, you're exhausted, and all the things she would be describing, but she loved it. She loved her job. She loved being a nurse. And I remember, patients would, when they would be discharged, they would, the families would give her gifts, and she would bring it home, and she would be so excited to share these stories about her patients, and she would know them by name. And I was like, man, that's a really cool job. And at the time, I went to one of these like polished, all boys prep schools in London, and I just it didn't feel like other people's parents. Obviously I didn't have as much money as them, but it didn't feel like other people's parents loved their job as much as mine did, as much as my mom did. And I was like, I just want to love my job as much as my mom does. And so when I went to college, I spent time shadowing doctors, and I shadowed a cardiothoracic surgeon. He seemed miserable. I was like, I don't want to do that. And then I shadowed an orthopedic surgeon actually at HSS, at Hospital for Special Surgery. So small world. I ended up working where I found my passion for orthopedics. But I shadowed this orthopedic surgeon, Dr. David Alchek, and his patients loved him. They would come back for their 6-month visit, and they would be like, "Thank you, doc. I'm back in the game." And he, his day just didn't seem like work. It just seemed like, diagnose a problem, provide a diagnosis, provide treatment path, care path, reassurance, and then, operate on patients, which is, pretty awesome. I love doing stuff with my hands. And then see them back and help them on the road to recovery, see them back at 6 months, a year, and wish them luck as they resume things that they love. And look, it's a little bit glorified. It's definitely not like that all the time. But in general, medicine, and specifically what I do, I help patients get better, and I have a huge impact on people's lives. And I love that. I wouldn't do anything else. And so what does the future look like, Porter? The future looks like, me being, squarely involved in medicine, because I love practicing medicine, but I also, I'm staying true to my MD MBA training. I think that you need people who can straddle the line between medicine and management and business, and can speak both languages. And so I'm looking forward to growing BICMD, growing this company to transform and elevate the way that we provide musculoskeletal care. I think that, ultimately we already are the largest network of musculoskeletal providers, but I think ultimately, we will be able to provide a comprehensive musculoskeletal solution. And I think that, as telemedicine and telehealth, continues to grow and people realize that it's here to stay, we're going to take away state-based practice regulations, right? Where you can be a New York physician and take care of a patient in California with no legal ramifications, right? And the practice of medicine is going to cross state lines. I think that that's going to happen pretty soon here in the next 2 years. And that's kind of where I see things going, and I'm excited for that.
Ben, I think you put your finger on something that is huge for the medical community. When you think about the standard of care 50 years ago, it was different in New York City than it was in some remote little community in northern Maine or someplace like that. But the standard of care really has evolved into a national standard. So I think you're right. The idea of having state licenses and the idea of having, control state by state over the practice of medicine just doesn't make good sense. What do you see are some of the advances that the orthopedic community is going to encounter? Are you going to be growing tissue, and instead of doing knee replacements, are you going to be able to infuse a knee with cartilage that was grown from the person's own cartilage, or things like that?
Yeah, no, that's a great question. So there was actually a recent orthopedic implant that got approved through the FDA, where you essentially can regrow an ACL, and that's huge. Right? Hasn't made a huge splash, but it's basically a graft that you lay it on, and you don't need an ACL reconstruction. Your own body will heal the ACL, and if that, the preliminary data is promising. And if that can take hold, obviously innovation can be slow when it comes to biologics and tissue, but that will have implications for other body parts, rotator cuff, things like that. We're already pushing the envelope in terms of biologics, PRP, stem cells, and right now we use cadaver tissue to replace cartilage defects. If we can regrow cartilage, that would be the holy grail. I think that that's 50 years away. So that's kind of on the biologic side. on the technology side, I think that we are knocking on the door for remote surgery, right? And that sort of, I think, as the door falls to practicing medicine across state lines, right? And Paul, you're exactly spot on. I think that in 50 years, people are going to be like, wait, what? You wouldn't let a doctor in New York take care of someone in New Jersey? That's ridiculous, right? So as the state lines get broken for just the simple practice of medicine, then you're going to get into regulation around practicing remote surgery. There's already technology that allows VR, right, where you can basically put on a helmet and essentially do the surgery or have someone's hands do the surgery. And so, you know, we're going to find here in the next 10 years that an orthopedic surgeon in New York may, maybe not 10 years, let's say 30 years, an orthopedic surgeon in New York may have a booming practice in LA where they're replacing knees and hips. And look, maybe not LA, but I think it has impact for providing care to underserved communities, right? Where, you know, yes, maybe we can have a doctor in New York who has a Manhattan practice do surgery for a West Virginia community that doesn't have access to the best orthopedic surgeon. And I think that that's the next evolution of orthopedic practice.
I think then if you were to help the workers' compensation community, and probably the medical community at large, in the best way possible, invent a definitive painometer where you could connect a patient to it, and they could determine whether or not the degree to which they're experiencing pain is accurate. Or reporting.
The outro meter. We just invented it on the call. The outro meter.
Hey, Paul, and I'm curious, your crystal ball on the legal side, if you had to think about how these issues will evolve in the coming years.
Well, I think they will. I think as the legal community develops closer relationships with the medical community, I think some of the approaches to these cases is going to be less litigious, and they're going to be more compromised. Let's work together. Let's figure out how to get people who are injured better and get them back on track. I see things like that happening. The other thing that I posed a question to a group of lawyers yesterday about what impact. I don't think a national medical system is on the horizon in the short term, but I think it is in the long term. And I think at some point a national medical system will have a profound impact as well.
I totally agree with all that, Paul.
Hey, one last set of questions that's come in for you, Ben, which is related to, is your company doing just second opinions or IMEs? And if you're doing IMEs, how do you guys think about that? What fits for you guys and what's not a fit?
Yeah, so right now we are only performing second opinions. We're not performing IMEs. Doesn't mean that that's not something that we're interested in. I think that there's definitely an opportunity to perform IMEs. Some of the doctors on our as part of our network, they perform IMEs, outside of BICMD. It gets into a question, and I would love to have Paul's insight on this. It ultimately gets into a question on what the courts see as necessary for an IME, right? So if you perform an IME and you have not had a physical examination, will an actual in-person physical examination, will the courts accept that if that doctor is opposed? I think some doctors have no problem doing IME and they have no problem doing it via telehealth, but what is the legal industry willing to accept for an IME?
I think Ben's approach is correct, Porter. The difficulty or the distinction between an IME in some jurisdictions and a second opinion is that in order to do an IME in some jurisdictions, you have to be approved by the jurisdiction. So it's essentially, it's not like a licensing procedure, but it's approval by the regulatory body. You don't have to be approved to do second opinion. So I think getting this business going or getting this whole operation going, getting themselves known, might open the door at some point to an IME, but I think he's taking the right step in doing second opinions initially.
Gotcha. All right. And as a doctor and a lawyer, both with pretty good outlooks on life, what do you guys recommend to stay sane during the pandemic as a final question? Any tips?
It's yours, Ben.
All right. So I have 2 tips, guys. We've been talking all business, so we're going to start with a couple of tips here. So first is get some workout buddies. So I'm fortunate enough to have gotten a Peloton, and I have my Peloton text thread where people will basically just shoot a text and they'll hop on the bike and I'll hop on the bike and we'll do the same class, and it's awesome. We like push each other, and I have major FOMO and guilt if when they send their scores and I'm like, I didn't do it, I was on the couch, right? And so that's a great way to stay sane and to work up a good sweat. And so um, I very much encourage that. And then the other thing is, take up a new hobby. So my new hobby is cooking. As crazy as that sounds, I never used to cook, but someone got me an air fryer for my birthday, and I've basically been exploring air fryer recipes. Who knew that air fryers were a niche within the cooking industry? So that's kind of my ways of staying sane.
I would agree with Ben on point number 1, and that is I have always exercised on a regular basis. I continue to exercise first thing in the morning, get up, and I usually do a couple miles. And then reading. I've been reading a lot more just because I'm not out, I'm not social, I'm not out and about, but I've actually read some terrific books over the past year. And spending more time with my spouse is another way to deal with this unusual situation that we're in. So those are my 3 recommendations.
Excellent. Well, guys, it's been a lot of fun. I hope we can get together in person at some point in the near future. And for the folks who attended, we'll send around Ben's information, Paul's contact too. And we are really excited, Ben, to work with you and Riley on the partnership to help our members as well, and to have you guys, supporting what we're doing and vice versa. So this was fantastic. Thank you, guys, and thanks.
Just before we leave, can I make it clear that our relationship here with Ben and his company is that we have a medical advisory group, and Ben and Riley, his business partner, are both part of our medical group, and they give us technical medical advice on things that we're dealing with as a business. And we, in turn, right, I'm not sure we give them advice about anything, but we try to help them out as well.
Exactly. We've already seen some of our members who had an injury and settled their case be interested in the second opinion service that Ben and Riley have through BICMD. So it's been a nice partnership.
Yeah, right. We're thoroughly excited, and I guess obviously I want you to have the last word, Porter. I feel like I haven't asked you any questions, so I guess the one question I would love to know, as you said 10 minutes, we have 2 more minutes. What's the transition been like for you to being CEO of Ametros?
Oh, thanks. Yeah, it's been a blast. Made the transition over about three months ago. My business partner there, Marcus, who transitioned on. He's still on our board, but really exciting opportunity for him. He's launching his own investment fund to invest around the country in Black-owned businesses or Black-led businesses. So I'm pumped for him. And then Ametros has been doing so well, and I get to work with guys like Paul and our senior team here. So the company's been expanding. Yeah, guys like Paul are keeping me under control. They keep me straight, and we're just having a great time. What we do, helping people every day that have had an injury. We're not in the midst of the action like you've been, but we have that shared mission. Making people's lives better. And so that's inspiring, and I think I get energy from that, and so does our team. So it's been a blessing.
I love that. Well, it looks like you have a great team around you, Porter. So it's a true privilege to work with you guys.
Thanks, Ben.
Well, thanks a lot, guys. We'll shut it down and look for the contact info. Thanks everybody for joining.
Take care.